Good afternoon, everyone, and thank you so much for joining us today. My name is Corey Ranger. I use he, him pronouns. I'm a registered nurse, and I'm the president of the Harm Reduction Nurses Association. And welcome to today's HRNA webinar, Perinatal Substance Use. We are so grateful to have clinical nurse educator Jen Boon here with us today. And I'm just going to go over a few pieces of information, some logistics, and of course, getting us started in a good way by acknowledging that I'm a settler on unceded stolen lands. I live on the unceded territory of the Cowichan tribe and what is colonially referred to as Duncan, BC. And the Harm Reduction Nurses Association does work with individuals and organizations across all of Turtle Island. And we honor the life force of Indigenous people who have had their land stolen and who continue to resist ongoing genocide. Addressing the root causes of the toxic drug supply is deeply connected to decolonization. I'd encourage everyone, if you can, if you feel okay with it, putting your land acknowledgement into the chat. We'd love to see that. I also acknowledge that the content that I get to talk to you all about, the content and the work that HRNA does, has been largely made possible by people with lived and living experience of criminalized drug use, sharing their knowledge and expertise with folks like myself. And so we wouldn't have vital life-saving harm reduction services like needle distribution programs, overdose prevention services, take home naloxone, were it not for people with lived and living experience taking the risk and innovating and keeping their communities alive and well while larger institutions and organizations lag behind in their response. For those of you who are unaware, the Harm Reduction Nurses Association is a Canadian national organization with a mission to advance harm reduction nursing through practice, education, research, and advocacy. We strive to achieve our mission by serving as a national voice for harm reduction and related nursing issues, promoting education and continuous learning opportunities for nurses, providing opportunities to share nursing knowledge, expertise, and practices, encouraging evidence-based harm reduction nursing practices, creating a dynamic network to support and mentor nurses across the country, advocating for the creation and implementation of harm reduction policies, working collaboratively with partners to address structural conditions that create harms, and advocating for the rights and dignity of people who use drugs and their families. If you haven't heard about us before, you should really consider becoming a member. It's super easy. We're not the most expensive organization. And if you like webinars like this, then you should become a member and support us so that we can keep doing this kind of work. There's lots of reasons to be a member, and I'll put the website directly into the chat when I'm done my part here today in case you're interested. And you don't have to be a nurse to be a member of the HRNA. We have associate membership categories. Before I hand things off, I do want to acknowledge we are, as always, talking about a difficult subject today. It is undoubtable that the people in the audience have not been in some way, shape, or form affected by the issues that we're discussing today. And so please know you can practice the principles of harm reduction on yourself. If you need to step back, if you need to walk away, if you need to take a break from today's content, then please feel free to do so. Your health and well-being is of the utmost importance. We're going to be recording today's session, and as soon as it comes time for questions and answers, we'll turn off the recording. So if you have a question but you don't want to be on the recording, then you can wait until I turn the recording off, and we'll have an opportunity for a discussion. And otherwise, please feel free to put your questions into the chat. I am pretty diligent about making sure I mute people who arrive because sometimes people forget to mute their mics, and we want to make sure that our presenter is able to speak clearly. And then without further ado, I'm so grateful to introduce Jen Boon today, Regional Clinical Nurse Educator for Perinatal Mental Health and Substance Use with Northern Health. Jen is the Regional Perinatal MHSU Educator for Northern Health. Jen's role is to support education around pregnant and newly parenting people who use substances. This includes education about reporting to MCFD, neonatal withdrawal, anti-stigma, and harm reduction practices for pregnancy, postpartum, and infant feeding. Jen is also able to help with specific families that come into your care for planning and connecting to community resources. I met Jen like a year ago and did like a presentation for Northern Health nurses. And we connected and chatted a little bit. And I'm just so happy that this has finally come to fruition. So thank you, Jen, for being here. I will stop sharing my screen and let you take over.
Awesome, thank you. While I'm getting my screen up, it would be great for me to see who everybody is. If you can just put your role in your chat, just so I can kind of get an idea of who we are chatting with here today. And just give me 1 second while we get this going. Is that good, Corey?
It looks great. And
Awesome.
right out of the gate, we've got Danny saying that they're a student LPN, Faith saying from Lipan Apache lands. We have a registered nurse and lactation consultant, an FASD program manager, a midwife with Waha Moose Factory, a nurse practitioner, a nurse practice consultant from Ontario. Wow, lots of diverse experience and lots of different settings folks are coming from.
Love that. Thank you for telling me all that. Okay, I can only see my presenter's notes here, Corey, so let me know if anything pops in the chat. You can just interrupt me as we go.
That's what I'm here for.
I love it. All right, everybody, thank you. As Corey already said, I'm Jen. I'm a regional clinical nurse educator with Northern Health. So essentially, that means that I am it for all of Northern Health for this particular topic. So, what I do is I do sessions like this. I teach nurses, physicians, allied health, any and everybody who's willing to hear me speak. I am always open to talk to. I'm acknowledging that I'm calling in today from the traditional territory of the Lheidli people, also known as Prince George, BC, and Northern Health acknowledges that we serve Inuit, First Nations, and Métis peoples all throughout our region, most with extremely rural places that they exist, and our job is to try and connect them to resources and to healthcare as much as possible.
You want to it?
So today we only have an hour together, so everything that I talk about will be really surface knowledge. If you want more information about anything, please feel free to reach out to me at any point, and I'm happy to connect with you. I will go over the Eat, Sleep, Consult program, which is what is called when you are treating babies with withdrawal. We'll talk about dyad care, which means keeping moms and babies together and the importance of advocating for that. We'll talk about supporting during reporting child protection concerns for us in BC. That's the Ministry of Children and Families, and I'm not sure what it's called in other provinces, but I'm sure it's not far off. And then just discussing harm reduction for perinatal population. I start all of my presentations with a self-assessment. So this is just for us to do in our heads and just get an idea of how we're showing up to this conversation. I imagine everybody that's coming here today is all of like-mindedness, but it's always good to do this first to set us in the right way. And I'll just read out the questions. So, do you believe that women who use opioids or have a substance use disorder can be a good mother? Do you believe that women who use opioids during pregnancy are responsible for the negative parts of their lives? Do you think that women using medication for treating opioid use disorder should try to cut down their dosage during pregnancy? And a couple more. Do you feel that the pregnancy or the birth of the child should be reason enough to stop substance use? Do you believe that relapse is a normal part of the recovery process? Do you believe that relapse indicates a lack of commitment to recovery and parenting? And do you believe you can tell by looking at a person if they have a history of substance use? I took this self-assessment from the Mothering and Opioids Toolkit. If you Google that, it'll come up right away. It's a super, super valuable resource. And again, this is not meant to make anyone feel bad about how they're showing up today, but just hopeful by the end of our hour together, we can shift some of these thoughts away from stigma. This little graphic is from the Academy of Perinatal Harm Reduction, and I think it really sums up our presentation nicely today, that the principles of perinatal specific harm reduction are about safety, autonomy, shared decision-making, informed consent is a huge piece, and do no harm. The parents and babies need each other. Substance use screening for pregnancy and postpartum really means screening all pregnant people, no matter what their job is, no matter what their lifestyle is. We need to be asking everybody the same questions at every single visit because we don't know exactly when they're going to start feeling safe talking to us about it. And the screening tools we have available to us are 4 or 5 Ps, a substance use risk profile, and then just that single screening question. But one thing about substance use screening is that urine drug testing should not be used as substance use screening. And this is slightly different in the perinatal population because this can really affect how the ministry or reporting child protection can use the urine drug testing in a negative way. We know that urine drug testing is not tell us how much, it does not tell us when, it doesn't tell us whether somebody knew they were using that particular substance or not. And sometimes, unfortunately, if somebody has a positive urine drug screen in their medical profile, that can be given to the Ministry of Children and Families, and it can be used against them. We also know that urine drug testing does not tell whether somebody can be a good parent. So we really need to be cognizant when we are using urine drug testing that we are using it with informed consent. Somebody knows what could come from it, and that we also are using it only to predict treatment if mom wants treatment. Urine drug testing should not be also used in place of the substance use screening questions. We don't want somebody to feel like they need to prove to us one way or another by using this particular test. We created this communication tool. I know this is busy, but this is a piece of paper that I've broken up into halves just for us to have as a visual, but this is a communication tool that we developed in Northern Health and that I can send to anybody if they feel like they want it for their practice. Essentially, it's a script for people who are not comfortable having these conversations. These are difficult conversations to have. The patients and the staff might not feel safe to have these conversations with each other. So essentially, we have this here saying, hello, my name is Jen. I'm a nurse. I'm here to support you. Please know that this is a judgment-free, safe space, and my priority is your well-being. And we also want to acknowledge, we have in the bottom of the blue box there, ensure that this patient knows that substance use on its own is not a reason to report to MCFD, where the ICFSA is the Indigenous Child Family and Services Agency. That's a huge barrier for people to admit to using substance use while they're pregnant. Sometimes, unfortunately, it's an immediate call. And what we also know in BC is that birth alerts are no longer legal. So if somebody comes in and is pregnant and is using substances, it is no longer legal to report them to the Ministry of Children and Families. And for the highly stigmatized population of pregnant people who use substances, developing that therapeutic rapport as the first interaction is of vital importance. If the client feels stigmatized and judged, there's a higher likelihood that they are not going to come back to you until it's time to birth their baby. So a warm, non-judgmental approach shows the individual that you are genuine in your desire to help and that you care about their well-being. If possible, we want to involve people with lived experience on our care teams to ensure we are walking alongside the client. We want to be talking with them, not at them. And this is particularly important during pregnancy. This is the last half of that communication tool. And it's just nice for staff to have questions to say, not always saying, don't say this or avoid this. What can we say? If you're comfortable sharing, how do you feel about that? And I acknowledge that you may not have felt supported before. Tell me more. I would like to know. And also this one here, we can talk again later. It's okay just because you started this communication that they don't have to tell you everything in this exact moment, that we can come back to it. And what we're talking a lot now is about our duty to support. So we have this duty to report that we all know is our legal duty. But what we want to really shift thinking into is we also have a moral duty to support. And that can be during reporting, that can be before reporting, that can be after reporting. But duty to support and harm reduction really do hand in hand. This slide is intentionally full just to show that there's endless ways we can help somebody big and small. The duty to support is a term that was coined by peers and people with lived experience, and they're grateful that they're beginning to see this term being used in health authorities and in policy. So this is just 25 ideas to support health and harm reduction at every stage in the pregnancy journey. Any of these points are relevant. Something as small as a smile is harm reduction. Support after childbirth is a huge known gap in care. So you have your baby, a couple days later, you have a baby wait or a public health nurse check-in, and then you're kind of on your own for 6 weeks unless something comes up and you reach out to care on your own. So for 6 weeks, somebody might not have any appointments. They might not have any connections to their community. So we really want to support this particular population. Can encourage them to go visit mom and baby support groups at their public libraries or friendship centers. Maybe we need to get them access to food banks and community kitchens. Maybe we just need to have safe use planning if that's what's safe for this family and education about the increased risk of overdose after pregnancy. Connection to community, connection to culture is a huge important piece for this particular population. And an uncomfortable sometimes, but important conversation to have is about breastfeeding and substance use. So clearly, we're not going to find any literature that says go ahead, breastfeed and use substances. That's totally fine. But what we are going to find is how to reduce harms while doing that. The only thing you're going to find always is that the unregulated drug supply, illicit toxic drug supply, however we want to say it, 96 hours between use and breastfeeding is what the literature says. So about 100 hours is what they found, but to say 4 days is easiest. So if somebody is using, we need to find a way to support their breastfeeding goals if that's what they're planning on doing, so they can pump and dump for 4 days and find them formula to use in between, and obviously ensuring that the baby has a safe caregiver for the entire time. For marijuana specifically, it's not obviously not recommended as THC accumulates in the breast milk, but what we can do is we can encourage low doses of THC and hand washing and wearing different clothes to smoke in, smoking away from the baby. For alcohol, we also know there's no known safe amount of alcohol in the breast milk, but we do know that 1 to 2 drinks has not been shown to be harmful to the baby. Binge drinking or heavy drinking regularly should be avoided, and we encourage breastfeeding before consuming alcohol. And for nicotine present in milk in a dose-dependent fashion, we encourage breastfeeding at least 2 hours after smoking or vaping rather than before, like we do with alcohol. And of course, hand washing and wearing different clothes to smoke in. And things to think about if we're doing teaching on lactation and substance use is the type of substance, how much people use and how often. How is the substance being used? Is it being inhaled, drank, injected? And what do we know about the short and long term effects of substances on the baby? We also need to consider the health of the person. So the person who is to be breastfeeding, are they able to hold the baby safely? Are they able to sleep safely with the baby? So there's a lot of things to consider when you're doing education on harm reduction and breastfeeding. But those two little graphics there, they are documents that you can also find: Taking Care, a short guide to breastfeeding and substance use, and best practice guidelines for mental health disorders in the perinatal period. Two really valuable resources that include education on breastfeeding and substance use. Pain in labor is an interesting topic because it can be really stigmatized as well. People who use substances will need more pain control. Managing pain in women with opiate use disorder can be challenging due to opiate intolerance, hyperalgia, and personal history of trauma impacting the overall pain experience. Inadequately treated pain is a risk factor for relapse. If somebody feels like their pain is intolerable, they will go and they will find other methods to control their pain. One thing that can be recommended in labor is to get an epidural, can really help manage pain. And then, of course, after C-section is a major abdominal surgery. We want to encourage them to take and be given appropriate pain methods. One thing that we recently created is a substance use safety plan for perinatal families. This was created with me with a peer. And one thing that this peer said is that oftentimes, especially when moms and babies are separated, they're very disconnected from their baby all of a sudden. And one thing that they wanted to encourage is for the babies to be acknowledged. So it says here, welcome to the world, little one, with baby's name and the baby's birth date. So even when the mom takes this piece of paper home, even if she's not going home with her baby, she still has this connection to her infant. And we put here that this document is a commitment between parent and child that supports loving intentions to ensure safety and success. So really positive intent with this safety plan. We have feeding here, so using their own pumped milk, or we have pasteurized donated human breast milk in some hospitals, or using store-bought infant formula. And then the second half of this piece of paper is how can we keep them safe with some options, and then also acknowledging that they may have a circle of support that they can turn to while they use substances, whether that's caring for the baby or caring for themselves. And for more safety planning, we think about using smaller doses, especially after extended periods without using. So oftentimes they're in hospital for 2 to 3 days. If they go back to use the same substances they maybe used before, their tolerance may have gone down, especially if they're having a neonatal intensive care unit stay where they're on or in hospital for a long period of time. We want to encourage them to only use one substance at a time and definitely not to try anything new. Getting their drugs checked where they're able to. Safe storage around children is a big important piece. And who they will call if they plan to use. Encourage them to use substances with people who know how to use Narcan, and especially making a parenting plan before any use, including childcare, feeding, and transportation. We have a virtual substance use clinic for perinatal families. We can give them the phone number to that if they choose to go seek out treatment, and encouraging the use of apps such as Lifeguard or Norse for safer use. I'll briefly go over the Eat, Sleep, Console program. So essentially, this is supporting babies with eating, sleeping, and consoling. And it's quite used now almost all over Canada and a lot of the US. And essentially, it encourages mom is medicine. So keeping moms and babies together is the goal of this program because we know that keeping moms and babies together gives babies the best chance at not needing treatment for their withdrawal in terms of medication. So before, we would have all these symptoms that I'll show you of baby withdrawal. We would tick off those symptoms on a little piece of paper and then we would treat them with morphine. But now we know that just because a baby has a ton of symptoms doesn't mean they need to be medicated. Maybe they just need more non-pharmacological support. And toxic stress is the biggest factor that pushes us towards better care. In the research, toxic stress is defined as the absence of the buffering protection of adult support. Without a parent or guardian responding to stress cues in a timely manner, the chance of harm is higher. For example, for a newborn baby, feeling hungry is a threat to their life, to them. So their perception that something is wrong sets off the crying alarm. If the baby has an adult who can tell what the crying means and tend to their needs, the baby develops a memory of satisfaction. The levels of stress hormones go down and the cycle goes on. But a child who is not satisfied will have stress hormones in their body for longer periods, and this can be toxic. We know there are harmful effects of dysregulation, can cause epigenetic changes caused by that separation. So our goal with this program also is keeping mums and babies together. That looks like rooming in and cue-based care and non-pharmacological care. There's a whole rooming in guidelines for British Columbia that was created there in 2020. And it just outlines what rooming in looks like in different types of areas and the benefits of it. We know that increases mother-infant bonding. We know that that means babies learn healthy attachment and providing a sense of safety and protection. We know that because of this, it decreases the need for medication. So morphine is what we treat babies with, which of course decreases the length of stay in hospital and cost. It increases the likelihood of parent involvement in the care when we're not separating moms and babies, decreases the chance of our Ministry of Children and Families involvement. It increases the chance of breastfeeding when moms and babies are together. Breastfeeding is safe with opiate agonist therapy. And if a baby is breastfeeding while mom is on opiate agonist therapy, then it decreases the symptoms because essentially she is using her breast milk to medicate baby. And of course, we know all the long-term health benefits for both mom and baby that do come from breastfeeding. And it also maintains a huge positive connection to the healthcare system. The difference between feeling supported and kept together with your infant, between the difference of when they're separated into different units or taken into custody by the ministry, they're probably more likely to feel safe and supported if they were to come back and have another baby. Our first line treatment for Eat Sleep Console is always, always non-pharmacological care. So all the normal things we're going to do to care for a baby who's not withdrawing. And then in a hospital environment, we're also going to add in rooming in, quiet environment, cue-based care, low lights, low noise, abrupt, loud movements we'll try to avoid. We're going to minimize painful procedures. We'll cluster our care with our assessments. If we have to do any blood work, we'll try and do it all at one time. And skincare. Oftentimes these babies get really bad diaper dermatitis, so basically a diaper rash. The second line treatment is morphine. We have this algorithm that looks super complicated, but essentially we always start with as needed morphine. And if that doesn't work, then we'll go to a regular morphine. And we can do 3 increases in this algorithm before we need to look outside of the algorithm. And that takes us outside of the Eat, Sleep, Console program. That usually just means that the baby just needs more complex care. These are the clinical presentation symptoms of neonatal withdrawal. And like I said, we used to just do little ticky boxes beside all the symptoms and make decisions on how the baby's doing based on that. But we know that a baby can be irritable with a high-pitched cry, having loose stools, having nasal stuffiness, doing a lot of sweating, and can just need to be swaddled and held and bounced and fed often. Doesn't mean they need morphine. But we can also have a baby who has tremors, vomiting, sweating, sneezing, all of the things, and they just might need morphine to be able to rest, to be able to have energy to eat. And we also know that if a baby has a ton of these symptoms all at once, it likely means that they were exposed to the unregulated drug supply, and that can make treating really complicated. This is a visual from the PSBC Health Hub. It shows the different substances and then also the different symptoms that can come with it. So it's also kind of another busy slide, but if you're a visual person like me, I like to see it laid out like that. And 2 points to make from this slide is one being that the unregulated drug supply allows for many different substances to be taken unknowingly, which also means more symptoms. And then the other point to make is that withdrawal from prescription and legal substances is also common. So on here we can see there's SSRIs, nicotine, caffeine, likely prescription opioids, and legal cannabis. And we can also see that methamphetamines, opioids, cannabis, inhalants, and nicotine can cause the same symptom as irritability. So it's important if we do have people who are normally stigmatized to be able to have trauma-informed and non-stigmatizing conversations about their baby's symptoms to get an idea. Maybe they have just been smoking a lot of cigarettes, or maybe that sometimes we get babies or moms are having a ton of caffeine or a lot of Diet Pepsi or iced tea in their pregnancy. And these babies are super jittery and irritable. So not jumping to any conclusions just based purely on symptoms. And this is a visual from the Canadian Pediatric Society that shows the onset of symptoms based on the agent. And I get this question a lot of when to expect symptoms to start. But the interesting point to be made here is that a baby can be largely into their withdrawal and then also start withdrawing from something else if they were using if the mom was using the unregulated drug supplies that has benzos in it. So hours to weeks, depending on the particular benzo that those symptoms can begin. So that really complicates the treatment as well. And these are the medications that are used for neonatal opioid withdrawal. Here in Prince George, babies are often given phenobarb. In some lower mainland hospitals in BC, they're given clonidine. I personally haven't seen methadone being used, but it was in the research. And then obviously morphine is our first pharmacological treatment choice. And just a note, even though I'm sure most people here understand this, but the fear of child apprehension, criminal prosecution, and community judgment and stigma exacerbate the cycle of victimization for our families. Stigma contributes to substance use being the leading cause of death in Canada. And that just leads me into having conversations about supporting child protection concerns that sometimes we need to report. We want to do our very best to include parents in the conversations, unless it is unsafe to do so. But letting them know your concerns for the baby's safety may prompt them to make the change and allow them to process what might come next. Having a worker show up to discuss removing baby from your care is incredibly traumatic to the families and significantly increases the chance of overdose and relapse. We want to ask for consent for sharing mom's medical information with child protection agencies. And for us, particular in BC, there's a specific form that they need to request and get signed in order to get information about mom without consent. We also need to consider that we make decisions about reporting, oftentimes based on many different factors, including our professional experiences, our personal values and beliefs, cultural influences, and our implicit biases. It's important to use our critical reflection during our assessment process when determining whether to make a child protection report. We want to think about what risks and harms do we foresee if we do or do not report. We want to think about what assumptions we are making about their ability to care for their baby, or maybe assumptions we're making about whether they do or do not have family support. We also want to consider that pregnancy and birth can really shift personal values. This might be somebody's very first time having so much interaction with the healthcare system, and this might be the first time somebody's considered making a change for themselves. So, how can we support that conversation? And we also want to consider the strengths versus deficits. Do they even want to parent? If they do want to parent and they have a strong bond with their partner and they love their baby, how can we really support that? And even if we do have to report, and sometimes we sadly do, how can we support them during reporting? Still need to connect them to community resources. We still need to ensure that they are safe when they leave the hospital without the baby. So we'll move on to kind of resources that we have here in Northern Health. These two web pages are public web pages. If you Google Northern Health perinatal mental health, you'll get this web page, and perinatal substance use, you'll get this other one. And it's kind of new to be able to have these conversations publicly, especially the perinatal substance use. We have that lactation specific harm reduction information straight on this public web page for people to access. And for both of these, there's emergency information and there's specific community information for every Northern Health community for people to access. And it's really exciting to see these things become more mainstream conversations for public. Other resources we have, which I'm happy to share with anybody who wants to borrow and copy to share the love. We have a poster or a little tear-off pad for units to have the virtual resources that are available for physicians. Having access to that information at 3 o'clock in the morning is a great resource to have. There's a ton of 24/7 resources available to us. We also have one called Eat, Sleep, Console Required Components, and this is for families and for staff, so everybody's on the same page of what care is expected to be given and what care is expected to be received. We have resources for each community in Northern Health, community resources and our health authority resources, including family services, friendship centers, breastfeeding support, and housing. We also have these 3 pages here from a little booklet we made called You Are the Best Treatment, and this is for families, information booklet for them so that they can get answers to questions they may not have known to ask or be giving information that staff may have not remembered to hand over. It's hard to give all the information. Sometimes can be overwhelming. So it's nice for these families to have these, even if they get them in pregnancy from healthcare providers. These are internal pages. So we have an internal My NH is what it's called. So we share all of our resources on these internal web pages, and it links also to external pages. It's a really good way for us to keep connected on what's new and what's coming up in resources. And then as things change, if say like the resource has expired or the information has changed, these web pages will always have the most up-to-date information. And I can share any information from these with anybody who wants to reach out. We have 2 policies coming out soon, which are very new and very forward thinking, if you will. So the first one being the duty to support families before, during, and after reporting child protection concerns. So this is kind of a step-by-step guide that will be coming out on how to make the decision to report and how we can support while we're having to make those hard decisions. And we also have this one too, which is really new, care of the perinatal person who uses substances. We know that the less antenatal care, so the less care somebody has during their pregnancy, the higher risk that they have for morbidity, mortality in the first year postpartum. So essentially, this policy says anytime somebody comes into the hospital, whether it's to birth or just to emergency or to ambulatory care, let's check in. Where are they at in their pregnancy? Do they need blood work? Do they need ultrasound? Do they need a connection to a provider? Oftentimes when people don't have the antenatal care, they get this tag of limited prenatal care. And that can really be stigmatizing how people interact with them. People thinking, oh, they just don't care about their pregnancy. Oh, they just didn't care about their baby. But they're already connecting with the healthcare system. So how can we meet them where they're at and get them the care that they otherwise would have gotten if perhaps they went to just an appointment at their doctor's office? And then we're also starting a mental health safety plan. There's already mental health safety plans everywhere, but there's nothing that includes women and children. So at the bottom, there's an acronym called NESTs, and this is really popular amongst perinatal worlds. So nutrition, exercise, sleep, rest, time for yourself, and support. So I've worked really hard on getting a mental health safety plan that also encompasses women and children. And then on the back of this plan also has a place for us to put where we plan for somebody to take care of our children if we need help. And then I've talked about the PSBC Health Hub a little bit here, but this is the QR code to the website. If you want to snap it, it has resources for healthcare providers and families. Anything that I have gotten today for my presentation has likely come from this. This is kind of our little Google for perinatal information. And it's actually really quite useful. It has best practice for healthcare providers and also things you can print off and give to families. And then I'll wrap it up with another thing from my favorite tool is Mothering Opioids Toolkit. Just 10 things pregnant and parenting women who use substances would like practitioners to know. And I find these to be a really impactful list, especially saying that mothers want to succeed. Don't assume
No.
we are not trying or that we chose the challenges we face. And showing empathy, not pity, compassion, less condensation. Be a support and get behind us. Be curious about what might work for each of us as individuals. And just because you're still using does not make you a bad mother. Not everyone takes the same path to recover. Listen to where each person is at in their journey. And lastly, don't judge, instead care. That is it for me. Please, please do feel free to reach out at any time. Happy to answer questions. I could probably talk about it all day. So doing it in 40 minutes or less is a tough challenge. I'll put this little Q&A slide up, but then I'll stop sharing so that we can see each other's faces.